Hello everyone, I'm Camila Scharf, and today in this podcast we will be discussing top clues to melanoma on sun damaged skin. When we think about melanoma, there are four subtypes that will usually come to our mind, which are lentigo maligna, superficial spreading, nodular, and acral. But when we think about sun damaged skin, there are two subtypes in which we need to focus a little bit more, and those are the lentigo maligna and the desmoplastic melanoma. Differential diagnosis is not always easy between the lentigo and pigmented actinic keratosis, solar lentigo, and lichen planus-like keratosis. In this paper published in 2014, some criteria have been described for the diagnosis and the management of facial pigmented lesions. And that's basically what we learned and what we've been doing in this past 10 years. So we've learned some classic criteria, and we will, every time we see a lesion, we will try to look for it. So every time we look at a lesion, we will try to find some gray dots and globules, asymmetric openings, circle or semicircles or circle within a circle, rhomboidal structures or obliterated follicles, and then the structureless areas. So when we look at the lesion and we see these asymmetric follicular openings, which are more visible in the beginning of the formation of the lesion, or the annular granular pattern, or these rhomboidal structures, and then finally, of course, the obliterated hair follicles, we will be very confident to do the diagnosis of this melanoma. And that's okay when we are dealing with melanomas that are clear-cut melanomas. When we look at it, it is very easy for us to say that there is something not right with the lesion, either because we were able to see one of these classic criteria or some other criteria described, such as the zigzag pattern, which might be the beginning, the incompletely formed rhomboidal structures. Okay, so we would look at the lesion, and then as soon as we see these asymmetrically pigmented follicular openings with some brown and gray color, or the obliteration of the pilosebaceous structures, we are able to look at it and say, yes, that's a lentigo maligna. And that's what we've been doing in all these past years. But the thing is that 10 years have passed, and now we are able to look at lesions such as this one and say that this is a melanoma. But in this case, there is no use into searching for all these classic melanoma criteria, because there are a few lesions now that when we look at it, we will not be able to see the rhomboidal structures, the asymmetric follicular openings, etc., etc., but we will still be able to look at it and say that it is a melanoma. And how? There is this very important paper that it's called the inverse approach, described by Lalas and Gepergenziano. And in this paper, there are 6 features that are important for us to know on how to recognize. And those are white and wide follicular rosettes, erythema, and scales, such as this, like white and wide follicular openings. The rosettes, which are these flower-like structures. And the erythema, which are all correlated with pigmented actinic keratosis. So when you look at a lesion, you're still not sure what it is, but you get to see this erythema, these scales that might be white, but might also be pigmented, such as these ones showed in the third image. And these white follicular openings with the rosettes, they are all signs of of pigmented actinic keratosis. While sharp demarcation fingerprints, or other classic criteria that we already know that are criteria of a seborrheic keratosis. So these fingerprint structures or the Scharf demarcation. Those are all criteria that will get us to the diagnosis of a solar lentigo or a seborrheic keratosis. So when we are faced with a lesion such as these two, okay, on image A, it is easy for us to recognize patterns of lentigo, of solar lentigo, while on image B, I cannot see scales, I cannot see erythema, I cannot see wide follicular openings or rosettes, I cannot see sharp demarcation, nor fingerprint structures, nor any classic criteria of a solar lentigo or a SEBK. So that automatically makes this lesion suspicious. Not because I get to see some classic criteria of melanoma, because I cannot, but because I cannot see what it's called these non-melanoma features. So if I do have one of these features predominantly visible, we are more certain of the benignity of this lesion. But if I cannot see any of these features, or if they're absent, or if they are present but non-predominant, this lesion is automatically suspicious. But remember, it needs to be predominant. So every time we have a lesion that is completely non-specific with this criteria, it is important to have an histological diagnosis. Another important aspect to consider in sun-damaged skin is when you do have a lesion that is suspicious, so you look at it and you might not like it, and considering that usually sun-damaged skin we will see on the face, it is very normal that we will perform incisional biopsies for these lesions. When you perform an incisional biopsy of a lesion that you're thinking is a melanoma, and your pathology report come back as a junctional nevus, be aware, talk to your pathologist, discuss for a revision, because on sun-damaged skin, it might happen the diagnosis of a junctional nevus in a lesion that is actually an early melanoma, as described in this paper published by our group. And finally, let's finish discussing a little bit about desmoplastic melanoma. And desmoplastic melanoma is a true clinical challenge, mostly because either half of these lesions actually show the typical melanocytic structures that we are used to. So usually what happens, what helps us in this case is that the vascular structures that are usually polymorphic and the crystalline structures might indicate us to this diagnosis. Also, the annular granular pattern or the scar aspect might be helpful. For example, in this case, which, okay, clinically it is already suspicious, mostly because we have this melanocytic irregular pattern in the borders, but in the center we do have a scar like aspect, and that needs to make us at least think of the possibility of a desmoplastic component of this lesion. Other times we might have a lesion that will clinically resemble lentigo or lentigo maligna, but when we look closely at dermoscopy, and what we see there in the center is this very typical and polymorphic vessels, that with that we should consider the possibility of a desmoplastic melanoma. And sometimes what we have is a lesion that in the beginning we might not even think that it is melanocytary, such as this, that could be easily a cranocytic tumor. But when we look closely and we see all these polymorphic vessels, remember of desmoplastic melanoma. So it's not always easy to do this differential diagnosis in sun damaged skin. Remember all these pigmented, benign, non-melanocytic lesions. But sometimes, instead of searching for the classic melanoma criteria that you know, try searching for what is not present. When we have follicular invasion and gray color, it's more easy for us. Otherwise, use the inverse approach because it allows us to gain sensitivity without losing specificity. Pigmented AKs and lichen planus-like keratosis might still represent a pitfall, even for experts, even in more advanced technologies. When we do, for instance, confocal microscopy, we still might be in trouble. But it's always important, some careful clinical pathology correlation and a good discussion with your pathologist for the best possible patient management.